Good afternoon. Welcome to the Center for Global Development. My name is Prashant Yadav. I'm a visiting fellow here at CGD. Thank you for the interest in this session on the role of private wholesalers and distributors. We have a very interesting presentation and a panel this afternoon. Before that, I'm going to start with commenting on two things. One is, if you are tweeting or using other kinds of social media, please use @CGDev and #CGDevTalks. Welcome also to those of you who are joining us on a webcast. We would love to get your comments and questions through Twitter. Once again, @CGDev, #CGDevTalks. Just a quick preamble to this particular session. So in most countries in the OECD world, we see that private wholesalers and private distributors are the ones who provide almost daily, sometimes more often than daily, deliveries to clinics, hospitals, retail pharmacies. And when we look at low and middle income countries, we see that structure changes. We don't see such a big presence of private wholesalers and distributors. The reasons are very many. So the session today is going to share some new findings, which the Gates Foundation had funded, and they'll tell us more about it. But also discussion on what do we do with our engagement model with private wholesalers and distributors, and what can we do collectively so that we do have a well-developed, healthy market for wholesaling and distribution, and that starts to serve as a more sustainable way for running global health supply chain. So that's our starting basis for this. CGD has done a lot of recent work in procurement. If you're interested, my colleague Janine Moran-Keller is someone I encourage you to talk to. And I also want to thank two of my colleagues, Noor Shafke and Julia Kaufman, who worked very hard to help organize this event. So thank you to them. And before inviting our first presenter, I also want to say that if you are making plans for post 5 o'clock, there is going to be a reception. So please make time to stay, and there'll be an opportunity to ask questions, have an informal discussion, both with the panelists, but also with all of you who've come here. So with that, I want to invite Clinton D'Souza, who's going to share with us the findings of a new project they've done. Clinton is the managing partner at Celsian Consulting, and in the past has worked at Imperial Logistics and the Partnership for Supply Chain Management, has worked in this area for many years, has been a part of a CGD working group. So welcome, Clinton.
Thank you, Prashant. All right, so the first thing I need to do is put the timer on, because Prashant did make it very clear that I will get yanked at 15 minutes. Good afternoon, everyone. Thank you very much for the opportunity to CGD for having the opportunity to come and present the findings of the study. So, do I press that? Ah, there we go. Okay, I'll go back. All right. So, jumping straight in, PFSCM was awarded a Gates Foundation funded grant back in November of 2018, and invited a couple of partners, PATH, Afrix Consulting and Strategnos, to participate in the project, which took place between January and September last year. Our mandate was to assess the business maturity, market dynamics, and quality assurance or quality management standards of private sector wholesalers and distributors of medical and pharmaceutical medical devices and pharmaceuticals across 5 African countries: Kenya, Uganda, Tanzania, Senegal, and Nigeria. We undertook an extensive literature review and created a full registry of all wholesalers and distributors we could find for each of these countries. We then narrowed down in each of those countries the number of wholesalers we wished to meet with an interview, approached many of them, and finally ended up interviewing a total of 47. We used a self-developed data collection tool, which helped us identify gaps and gain insights into these organizations, their aspirations, their challenges, and where they were succeeding. The study was not without its limitations. We also identified regional players with operations in multiple countries and assessed their impact on the sector as well. In this table, we developed, using the business maturity, quality management, and impact on market dynamics, we created a table or a grading system rather, which helped us classify these wholesalers into what we termed performing, evolving, and developing. And this table is the result of those summaries. The largest takeaway, which is really the good news of the study, is that a significant percentage of the wholesalers that we visited fall into either the performing or the evolving categories, which was great news for us. And I think it's great news for everyone. It's great news for manufacturers of both medical device and pharmaceutical distributors. It's great news for governments if they're looking for sources of local quality products and to access from, and for donors who are maybe looking to move more of their procurement to local sources. So, very dense slide, but what we synthesized from the results was what we termed market archetypes, and we divided the 5 countries into 3 basic archetypes. The first archetype is characterized as sort of large, developing markets that are principally private sector driven. So, So in number 1, Kenya, Nigeria, were classified into this area, into this archetype. The QA standards and regulatory compliance in those 2 countries were generally very high across all the companies that we interviewed. The markets themselves, however, are rather fragmented. The closer you get down to the last mile, we'll talk a little bit about that more, with a whole lot of sub-wholesalers downstream, and that creates problems or challenges with transparency or traceability of product as you go further into the market. We also found in these markets fairly high levels of local production or manufacturing activity. Our study suggests that within these markets, stakeholders, whoever they might be, would easily find partners, multiple partners with which to partner to work with in these countries. Archetype 2, Uganda and Tanzania, would fall into a category characterized by sort of lower maturity levels, smaller organizations, fewer of those organizations reaching high standards of QA and geographic reach, and fairly heavily donor-driven in their pharmaceutical markets. So governments and donors are a big percentage of those local markets from what we saw. HR skills were highlighted on a number of occasions in these markets as a challenge. So access to good QA people, etc. We found high prevalence of generic pharmaceuticals in these markets versus archetype 1 that exhibited a broader mix. Of interest is that in these markets there were programs that supported the downstream informal drug shops. So there were programs in place that helped the quality of those downstream outlets and facilities. There was some interest in local manufacturing, though the barriers in these markets are very high for local manufacturers. And then we really weren't too sure what to do with Senegal, so we had to come up with its own archetype because it is not characterized by anything that we saw anywhere else at all. In that the markets themselves are actually very consolidated, small number 3 really big players that are dominant in that space, that are largely managed and run out of Europe rather than run locally, and are part of sort of these multinational organizations. We found generally very high standards of quality among these wholesalers, very good HR skills within these companies. The regulators play a big role in these markets, and a significant thing that we found was that the regulator in Senegal insisted that all drugs imported met SRA standards, which largely means that the products coming into these markets were innovative products coming in from, for example, Europe. So really here we just try to define separately the differences between medical devices and pharmaceuticals across all the markets. And we looked at things like markups and coverage and a number of wholesalers, etc. And as you can see, they're literally counter to each other in almost every instance. So these are very different. Whilst our mandate was to go in and look at both, when we did look at both, there is very little in common with both. I think the one thing I didn't mention earlier is that we further divided medical devices into durable and non-durable, and specifically the durable wholesalers are characterized very different from non-durable and pharmaceuticals. Moving on to the key findings. So throughout our study, we had 4 common sort of limitations or barriers that were expressed by the interviewees: operational performance, financing, regulation, and quality. And so we're now going to try and dive into just one slide on each of these to sort of give you the high-level findings. So in terms of operational performance, some of the challenges included the ability of smaller players who exhibited great potential to invest in their quality management systems. So they may have the beginnings of good systems, but they did not have the means with which to progress those systems to full capacity. Another thing that we found that sort of contributes and creates another barrier downstream was exclusive agreements between manufacturers and wholesaler distributors. And so whilst these are good for manufacturers because they've got a single point to invest in, a single organization to work with, it creates limitations in the market and drives up price because you end up with sub-distributors and further distributorships downstream. And obviously, as a result of a lot of this, private sector commodity prices were higher than the public sector prices. Some of the opportunities that we thought of and came across from what different organizations were doing was sort of things like mobile money or system automation is something some of them are trying to do. One of them was trying to establish a common durable device installation and maintenance service. So as we know, a manufacturer of durable devices may appoint a single distributor, and then they spend all this time and money training people to service their products. But each manufacturer of a different device does this, and so you end up with lots of people looking after 1 or 2 machines, and so was there an opportunity to consolidate some of those. As within the public sector, access to private sector data remains a challenge. So as much as we beat ourselves up in public health about lack of data, in the private sector, there really is a pretty big lack of data as well. And so this was an area that we thought would warrant some more investigation. And the last thing we came up with, and there were various initiatives in countries around either pooled procurement or group purchasing, or some kind of aggregated demand and importation of commodities created or potentially led to an opportunity for wholesalers to do something collectively to drive down price within their markets. And so, so the last thing to say on this is that, the technical skills to tackle any of these are really not there, not prevalent in many of the companies that we spoke to. Finance. pretty intuitive. Cost of money in all these markets is extremely high. The smaller players have to borrow money to make the procurements. They get some, if they've been a client of a manufacturer for some time, they might get 90 days credit terms from the manufacturer, but their cash cycle is 10 months, 12 months, and so they've got to carry that balance. The interest rates are very high in most of these countries, and so the cost of money is just huge, and a big barrier for many of these players. So, there are existing options or solutions out there, including favorable debt financing mechanisms, etc. Again, framework contracts to try and drive down prices in the first instance. And another thing that we saw in one particular organization is manufacturers moving the product closer to the markets. So rather than manufacturers holding the stock in Europe or in China or whatever, move them closer so that the wholesalers don't have to buy a whole container worth of stock. They can get stock, less of it at a time, less cash to outlay. They can turn that into cash faster. So, are manufacturers prepared to move stock closer to the markets? Regulation. This was not a mandate in our study at all. But as we were talking to these wholesalers, it became very clear that this is a major issue for all of them, and so we would be negligent not to mention this at all. So, firstly, I think one of the major barriers is, as we looked at all these countries, each of these countries, with the exception of Senegal, ran into hundreds of wholesalers registered in each of these countries, and so the capacity of regulators to regulate hundreds of wholesalers in these countries is just not possible. The other thing we noticed is that the further away you got from the capital city where the regulator sat, the less likely you were to encounter the regulator. So if you sat in the capital, you were going to get visited fairly regularly, but if you sat in the regions, they almost never got there. If you were a pharmacy in some village somewhere, you never saw a regulator at all. And so, these were some of the challenges. And perhaps the most significant takeaway from this is in the bigger markets like Nigeria and Kenya, because a lot of the retailers of pharmaceuticals are not registered, yet the letter of the law says they need to be registered, the manufacturers that we spoke to didn't sell directly to these shops, these pharmacies. They sold to sub-wholesalers. And this is where the whole visibility and traceability issue goes away. And so then what product is else bought by some of these places? All right, that's me trying to get done. So regulation we have to address. This was just an interesting table that we compiled out of quality management systems. And again, it showed generally very good potential for quality management aspirations. I think this column here, the evolving column, really talks to companies that exhibit all the right behavior but lack the investment to be able to progress their QMSs beyond, though many aspire to things like ISO 9000. So these were just some takeaways, some of which I've talked about here, and in the interests of time, I'll leave this. I think the panel are going to talk about some of these potential things here. And so if I may, for just 1 minute, I'd like to just thank a few people. Firstly, to the foundation folks, Prashant, who started the process, to Anne and Jess, who stuck with us and really gave us tremendous guidance and patience with us. We greatly appreciate it. It was a lot of fun to do, maybe not in October, but it was a lot of fun generally, and we really appreciated the opportunity. To the leadership of PFSCM, Edward, Erin, Alexis, and the team, they gave the whole team a lot of freedom to really run and express this project, and so we want to thank them very much as well for letting us do it. To the core team that really made the ships run, Bavia, who's here, Lisa from Path, Johnny, Evan, Marcel, Carrie, Janet, Manasika, Britta, I'm sure I've left a few out, but these people were the people who went into all these markets, spoke to all these wholesalers and spent weeks and weeks of their lives helping us gather all this data. And so without them, there would certainly be no project. And then the final two who really were stand out for us, the first is Dan. Just quickly stand up, Dan. Dan Rosen was our data market dynamics guru, and we wouldn't have gotten started and frankly finished without Dan. So thank you very, very much, Dan. And then Theano Cosmas from Strategnos, who was our project manager, and I think we'd still be writing these reports without Theano. So Theano did an amazing job of keeping us all in check, even though we didn't like her a lot of the time when she was pushing us like that, but it was wonderful. And the last thing I'll say is that we will share through CGD where all of the public documents are available. I'm not sure where we finally landed on that, but they're all ready, it's all done. We've just got to make it available publicly to everyone. Thank you very much. I'm going to take that if that's okay.
Thank you. Thank you, Clinton. We'll reserve questions for Clinton during the panel Q&A. And we'll move to our next speaker, which is Dr. Dominic Babo from the Democratic Republic of Congo. Dr. Babo heads the World Bank-sponsored Health System Strengthening Project. They are doing something very interesting and impactful with the use of private wholesalers in the DRC. And he'll give us short remarks about what that project is, what its genesis is, where they're headed. His remarks and talk will be in French. We will have a simultaneous translation along with it. Thank you. Dr. Babo, welcome.
Messieurs et dames, bonjour.
Good afternoon, ladies and gentlemen.
Voilà, donc je vais vous parler d'un projet qui s'est mis en œuvre en RDC.
Today I'd like to talk to you about a project that is being implemented in the DRC.
C'est un projet qui est projet du gouvernement congolais, mais financé par la Banque mondiale.
This is a DRC government project that is funded by the World Bank.
Et ce projet, c'est un projet qui a comme objectif améliorer le soin pour la mère et les enfants.
The objective of the project is to improve maternal and child health care.
Et donc, naturellement, pour arriver à offrir des soins de qualité, on a besoin de médicaments.
Of course, in order to be able to offer quality care, you need medicine.
Et dans notre pays, il y a deux systèmes d'approvisionnement médicaments qui existent.
In my country, we have two systems that exist that supply medicines.
Principalement un système biblique.
We have the public system.
Et ce système-là est organisé autour de deux dispositifs.
Which is organized into two main mechanisms.
Il y a un dispositif d'achat groupé.
There's a pooled procurement mechanism.
Et il y a des centrales de distribution au niveau périphérique.
And then at a decentralized level, we have the distributors.
Et donc c'est ce système qui est privilégié pour la plupart des projets qui sont développés en RDC.
This is the system that is preferred for most of the projects that are implemented in the DRC.
Malheureusement, ce système a ses limites.
But unfortunately, the system has some limitations.
Parce que pour ceux-là qui ne le savent pas, le Congo, c'est un pays très large avec des contextes variables.
Because for those of you who don't know, DRC is a very large country and the context can change a lot from area to area.
Et donc, toutes les provinces n'ont pas le même dispositif, ou du moins le dispositif n'est pas aussi performant partout.
Not all of the provinces have the same mechanisms in place, and even if they do, they're not all performing at the same level in every province.
Et de l'autre côté, il y a un secteur privé.
In addition to all of that, we have the private sector.
Et du côté privé, comme on l'a dit même pour l'étude qui vient d'être présentée,
With regard to the private sector, and this was said in regards to the presentation that was just given,
il y a beaucoup d'acteurs qui interviennent.
You have a lot of different players in the private sector,
Beaucoup plus de distributeurs que de fabricants.
and you have many more distributors than you have manufacturers.
Mais c'est du fait de une faible régulation.
That is because regulation is quite weak.
Il est vraiment difficile d'assurer la qualité de médicaments et d'autres produits de santé qui sont distribués par ces systèmes-là.
And so it is very difficult to do quality assurance of the medicines and other health products that are distributed through the private system.
Donc, lorsqu'on est appelé à mettre en œuvre un projet
That means that when we have to implement a project,
et pour lequel les médicaments est un élément central,
and when you are dealing with the main medicines that people need,
il est difficile d'avancer si on ne donne pas, ou plutôt on ne renforce pas les systèmes existants.
it will be very hard to move forward and improve that without first strengthening the system that already exists.
Ok, et donc au niveau de notre pays, du fait que le système public présente certaines faiblesses,
Because of the weaknesses of the public system that I just described,
nous sommes en train de mettre en place un dispositif qui permet d'intégrer le secteur privé dans la distribution de médicaments.
we are trying to put in place a mechanism that will bring the private sector into distribution of medicines.
Et comme le système privé, nous l'avons dit, avec une faible régulation, on n'a pas vraiment de garantie sur la qualité des médicaments.
As I said, the private sector, the regulation there is weak. There's not a lot of quality assurance of the medicines.
Donc, on a mis en place un dispositif de certification de distributeurs privés.
So to deal with that, we've put in place a mechanism to certify the private distributors.
Et donc, c'est sur ces dispositifs qu'on est en train de travailler. En fait, ça pourra nous permettre, nous espérons, d'assurer la disponibilité des médicaments.
We're currently working on that mechanism, and it will help us make sure that medicines are actually available.
Parce que ces médicaments sont déjà là.
Because the medicines are there, they already exist.
Mais il faut assurer que c'est des médicaments de qualité.
But we need to make sure that these are quality medicines.
Et c'est pour cela que les dispositifs de certification deviennent un élément clé.
That is why the certification mechanism is a really key component of this project.
Et ce processus de certification, comme j'ai dit, a, je dirais, un avantage du côté du système de santé en termes de disponibilité des médicaments de qualité.
The certification process that I described offers a major advantage when it comes to quality assurance of medicines.
Mais aussi du côté des fournisseurs, des distributeurs qui sont les hommes d'affaires.
It also helps the wholesalers and distributors who are business people.
C'est une opportunité, c'est un marché de plus qui leur est offert.
It gives them an opportunity to access another market.
Voilà, et donc c'est sur ça que nous sommes en train de travailler à travers ces dispositifs-là, renforcer la régulation.
So that is the main component that we're working on in addition to trying to improve regulation.
Et motiver les privés à faire les affaires avec les structures de santé.
And encourage private entities to do business with these health facilities.
Voilà, donc c'est sur ça que nous travaillons, mais il est important de souligner que pour y arriver, il y a également ce besoin d'un appui technique pour aider le système privé aussi à s'adapter à cette nouvelle demande.
It's important to underscore at the same time that we do have needs for technical assistance in order to help the private sector meet these standards.
Voilà, nous vous remercions pour votre attention.
Thank you very much for your attention.
Thank you, Dr. Babo. And once again, we'll reserve our questions, which I'm sure many of you have, as do I, to Dr. Babo. And we'll have some more discussion on this project at the panel. So with that, let me invite my panel to the stage here. So first of all, thank you all for joining this important discussion here at CGT. I won't go and do a detailed introduction to each of our panelists. Their bios are here in a handout that you may have picked up at the front desk. But I'll just do a very quick introduction of the panel so you know what kind of perspectives they're bringing. So on the extreme left is Mark Parrish. Mark is the president of the International Federation of Pharmaceutical Wholesalers. This is the body that the large wholesalers and distributors, they're their own organization. Mark is also the chairman of the board of Trident USA and has served many large private organizations in helping them improve their efficiency and in leadership roles. To the right of Mark is Ann Allen. Ann is a program officer at the Gates Foundation in the Systems Innovation Group and manages many of their supply chain grants, including the one that we heard from Clinton about. To the right of Ann is James Maloney. James is the chief of the division of supply chain for health division at USAID, where he oversees the commodity procurement supply chain project for PEPFAR. In the past, he's been in Haiti and South Africa and has managed supply chain and health functions for USAID. To his right is John Simon. John is a managing partner at Total Impact Capital. Before this, John was the U.S. ambassador to the African Union, the executive vice president of the Overseas Private Investment Corporation, and most importantly was a visiting fellow here at the Center for Global Development. So welcome back, John. And to John's right is Lombe Kasonde. Lombe is a health specialist at the World Bank. She's worked both at the bank but also at other institutions in global health such as UNICEF and Gavi, and also in the private sector at GlaxoSmithKline, brings a rich experience and also has been leading this project in the DRC, which we heard from Dr. Babo from the bank's unit in DC. So welcome, everyone. Let me start with Ann. We heard from Clinton, interesting findings, opportunities. The foundation funded this grant. Where do you see opportunities to take some of this thinking forward, both for the foundation, but also for the larger set of stakeholders in global health, things that we could do in the more immediate term, things that we could do in the longer term?
Thanks, Prashant, and thanks everyone who joined today. So I'd like to pick up first on a few topics that Clinton mentioned that we see as opportunities writ large, and then I'll speak a little bit more specifically about what the foundation is thinking about in terms of next steps. I think that Clinton highlighted a few findings that touched upon opportunities more for intervening at the wholesaler distributor individual level as well as the ecosystem as a whole. I'd like to just call attention to three broad areas which are not all achievable in the short term, but I think are really critical to the success of and the integration of the private wholesalers and distributors to achieve global health supply chain outcomes. The first area I'd like to reiterate is the access to affordable finance. This is both from a fixed capital or to cover fixed costs as well as the working capital constraints that especially the small to middle-sized wholesalers are experiencing. When not part of an international conglomerate, they often cited this as a constraint not only to facilitate optimal ordering and stocking behavior, but also to upgrade IT systems or to invest in the skills necessary to achieve operational efficiencies. So I think this is a really important finding that we're interested also to pursue more in terms of how can we alleviate this burden, how can we shorten the credit cycle. Clinton gave a couple examples around moving inventory closer to a specific country or region, encouraging manufacturers to consider a vendor-managed inventory approach. There's also an angle that I'm glad will be covered here on the panel around helping wholesalers and distributors to better assess credit worthiness for their own clients. And I think this is an interesting area to continue and an opportunity for the community. The second one that I'd like to highlight is more in the realm of policy reform. I think there's two specific examples there. One is a policy reform linked to the registration of wholesalers themselves. So pulling from an example from China, who has tied their wholesaler registration to achieving GDP, good distribution practices, for instance, or having adequate cold chain capacity or the ability to track and trace within their supply chain, I think is an interesting angle to pursue in terms of lowering some of those barriers to entry for new wholesalers and distributors right now, which was often cited as a cause for the proliferation of upwards of 2,000 registered wholesalers and distributors in markets like Nigeria. The second policy angle that I'd like to highlight is related to formalizing the informal sector. So we've seen positive examples of that with the accredited drug dispensing outlets in Tanzania, or the patent you're going to make me say it, PPMVs in Nigeria, patent proprietary medicine vendors in Nigeria, and that has allowed the wholesalers to legally distribute directly to some of the smaller informal outlets, and also aligns incentives in the sense that they do not need to rely on sub-wholesalers and more tiers in that supply chain. Lastly, in terms of general opportunities, we definitely have to touch back on to the topic of quality and the fact that these wholesalers and distributors are relying on a national regulatory body that is woefully under-resourced. So as long as that continues to be a case, I think we will not see the kind of quality medicines and quality oversight over this market. Even as consolidation occurs and that burden reduces for national regulatory bodies, I think we need to explore opportunities to alleviate and strengthen that quality assurance mechanism. And there are different ways that we could approach that issue as well. So from a foundation perspective, the findings are relatively new. And we're very excited to look forward into a relatively new area of focus for the foundation in terms of the private channel, and to continue to build on this evidence base that was collected, and also to disseminate it to a variety of decision makers in this space, from manufacturers in the selection of their distributors and wholesalers, to governments and our other donor partners who we collaborate with in this space. I think this information is particularly interesting for some of our upstream colleagues who are looking at how to introduce new innovative medical devices, for example, and are trying to better understand what the market for distributors looks like. Do they have the necessary capabilities to basically bring some of the innovations from our pipeline to scale? So that's a very concrete example from both a supply chain and, I would say, market shaping point of view. We have prioritized this as an area of focus going forward, and we will be looking to be making more investments in this space. Unfortunately, it's just too early for us to be more explicit about where we see the focus. However, I think it's safe to say that as the grant-making part of the Gates Foundation, we wouldn't be looking at individual interventions into a wholesaler. We would reserve that for more of our strategic investing fund side of the house. But we would be looking at that ecosystem, and together with some of our other global health donor supply chain partners, thinking through what are those multiple interventions that could contribute to enabling the environment and nudging the market to what we see as a more ideal situation.
That's exciting.
I don't know how I did on time. But.
Yeah, very good. So, but I think the fact that Clinton's presentation showed us that a large number of the wholesalers are either already meeting a high standard and maturity or are close in evolving. And then we heard from Dr. Babo that they are trying something like this in the DRC. it seems like there is a unusual convergence where we're seeing evidence that things are feasible, there are reasonably well-developed wholesalers, distributors. We'll hear more about solution sets. So, I mean, to me, it's a very opportune time to think somewhat more boldly around this area. And I'm not asking you to commit on behalf of the Gates Foundation, but I feel this is an exciting moment for where we are in this discussion with wholesalers and distributors. Well, thank you. Let me go to Mark. Mark, your companies are the mainstay of distribution everywhere that many of us see. They have massive distribution infrastructure. They go several times a day. As you talk to your companies, member companies, are they getting interested about sub-Saharan Africa, low and middle income countries? Are they thinking about starting operations there, or are they saying we'll rather partner with somebody and provide our expertise? Where do you see this landscape from what your member companies are telling you? And also from what you heard from Clinton and from Anne, are we missing any opportunities that we ought to be looking at?
Well, thank you, Prashant. Thank you for putting on this event and this very important topic. The answer is a complicated one. The reality is there are members of IFPW today that are multinational companies, and Clinton touched on this, that are operating in a number of these marketplaces and have an interest in continuing to operate. There are also a large number of private wholesalers in these markets that are operating just singly in that market, that are trying to better themselves, if you will. And one of the initiatives we've pursued at IFPW is to help create a African pharmaceutical distribution agency, which is the first of its kind. It's a Pan-African association, and one of our members, Strategnos, is here today. It's an early stage effort, but the intent there is to begin to try to coalesce around some common issues that the association can work with governmental agencies and the member companies to try to create some initiatives to move forward. Anne mentioned China as a good example, and also what's going on in the DRC. And in both those situations, the government and the industry began to work together to try to raise the bar. Now, obviously in that equation, the government has more leverage, but if the government is bringing the right intent to the program, that will create a more vibrant marketplace and increase the regulatory compliance requirements, which allows for wholesalers to go ahead and make investments, because that act of beginning to raise the bar begins to cut out the number of people, and then it's easier for investors and lending institutions to choose the companies that they feel they're comfortable in supporting, because they can't support everyone. They have to try to identify companies that they believe are going to be successful. When you talk about some of the large players in the pharmaceutical distribution industry, this is in the United States, McKesson, AmerisourceBergen, in Europe, Boots Alliance, and in China, you have Sinopharm, China Natural Resources, and a number of large players in other parts of Asia and also Latin America. Those companies, it's probably too early for them to have an interest necessarily in operating within Africa. But from the standpoint of sharing of resources, there are active programs right now, and we're working with Gavi as an example, where we are helping to train supply chain professionals that are working on the Gavi programs in certain countries by having members of IFPW share employees to come down and actually train supply chain managers, and specifically Europharma as a wholesaler member, as well as GSK and Merck have offered executives where we've actually put those executives on the ground in these countries to work with supply chain managers who are actively working in the system. It's sort of a extracurricular education for them. They're full-time employed in supply chain management, and they're getting additional skills as a result of that. One of the skill areas that Clinton mentioned specifically, interestingly enough, is HR skills and leadership skills, management skills. how to bring an organization forward in capacity, forward in capabilities, requires a certain amount of management talent, and that requires some training. The people are there, they have the raw talent, but they don't necessarily have the processes to do it. But once you begin to build that into place, then you can start approaching some of the more sophisticated IT systems that Ann is talking about, the quality systems that Clinton is talking about. But you fundamentally have to, we believe, invest in the supply chain management professionals on the ground, and then working with the regulatory climate, that begins to actually build up a system. Takes a little bit of time, unfortunately. It's not a quick answer, but it is one that works, and we've seen it across the globe.
So it's great that you're working with Gavi and helping colleagues in ministries of health upgrade their supply chain management skills by connecting them with professionals from your member companies. But more tactically, if I'm one of the wholesalers, which in Clinton's presentation was in the evolving, developing, and I want to get to the next level, and I'm seeking help, do I write to Mark Parrish or to his colleague Chris and say, I need help learning from Cardinal or AmerisourceBergen or Sinopharm or any of our member companies?
Well, I'm glad
what can we do to create that structure?
You contact the African Pharmaceutical Distribution
Contact
Association.
okay. Good to know, at least there is a structure.
That was the intent, was to create a structure by which we could begin to make connections. And I've got to give Clinton a lot of credit. He was, as a member of IFPW, instrumental in helping us to get to the point where I actually pursued this initiative.
Okay, good.
Excuse me.
James, USAID has a very large program in global health supply chains, both in procurement and distribution, technical assistance. Give us examples, if you have, of where USAID, PEPFAR have worked with private wholesalers in the past, and given the findings that you see and other developments in the landscape that I'm sure you're observing as much closer, where do you see future programming getting impacted by this? I mean, I know there is a new global health award design coming up in some time. So are we going to see more programming that will take private wholesalers and private distributors into account? And what have we done in the past with this?
Right.
I don't know if that's too much to ask, but I think people here are keen to see what you are planning to do with this.
Yeah. Well, and first of all, thanks again to the center for pulling this panel together. I think you're right. It's an exciting time. I think maybe to bring it up a bit to the strategic level of how we're thinking about global health supply chains within USAID as a development agency, but then I'll dig in maybe to some of those examples of where our current project and the countries we're working with are implementing. But I think there are kind of two pieces that are really driving where we are with strategy. One is the journey to self-reliance and helping countries advance within supply chain maturity within the countries. But the other one is also the private sector engagement. But I think at the end of the day, what we want to help enable is client-centered supply chains. So that means that we actually have, the products with the clients when they need them, that they're of the right quality, and that should be our vision. So I think and I see some familiar faces in the room, and I'll just make a disclaimer at the front. I'm in the Office of HIV. There's some colleagues here from our malaria team. I see some folks from family planning, reproductive health, maternal child health. So even in the reception afterwards, if we want to dig into each of the areas, we can. But kind of a high level that we've actually done a lot of work in the last year with Gates and Global Fund and other stakeholders is to kind of lay out these strategic priorities. So I'll run through them quickly and dig into some examples. So one of the things we've agreed that we want to do is really be strategic with the supply chain and do some strategic segmentation. So what I mean by that is actually looking at the product characteristic itself, but also looking at the client we're serving, and really trying to be deliberate at looking at the channels then to serve those clients or those patients where they are. Within the HIV space, we're getting to a place where the epidemic is evolving. Lots of countries are getting to epidemic or closer to epidemic control of HIV, up to 80-90% of patients on treatment. So the ones that we're trying to reach right now are actually very difficult. So all the channels we have had in the past to deliver products or drugs, ARV drugs to them may not be the ones we need to kind of get to the very last mile. So I think that's key, is really to look at the strategic segmentation. The second one then is thinking about, well, who does that well? It's the private sector, right? They're very good at knowing who the client is and how to serve that client and make sure that products get to client. And so I think it's really at looking at the regional capacities, the in-country capacity. Assessments like this do indicate that, like you guys are saying, that there is developing private sector capacity in these countries. How do we position countries in to be able to leverage that capacity that exists, especially as we look at that kind of last mile distribution challenge? The third piece then related to that is the work we need to do with host governments, ministries of health, in terms of the technical assistance we provide for those governments to productively and to have an actual productive partnership with the private sector in the country. Contracting with the private sector isn't a silver bullet. You actually have to write good contracts. You have to have oversight of those contracts. So I think some of the technical assistance that we provide as the U.S. government, as USAID, also needs to be deliberate in focusing in on those areas. And even as this assessment shows, the critical questions around quality is another area where I think supporting governments in their regulatory capacity around quality and technical assistance in this area is a critical one. The fourth, which is really, I think, enabling here, is the piece around end-to-end data visibility. And I think you see it come up here, and some of the comments even made about kind of the fixed capital costs, right, of either the quality systems or some of the IT infrastructure needed. But I think really working with governments to drive innovations with whether it's the GS1 standards and track and trace capabilities, looking at what wholesalers have, for example, in terms of good distribution practices and standards, accreditation there, but also the ability to do recall management if that's needed. Having that traceability is quite a key place to that, and actually knowing we're delivering products to the last mile is really where the end-to-end visibility is a critical enabling factor. And then fifth, and there's kind of two pieces to this, is I think as we continue this collaboration with other donors, other stakeholders, look to build these public-private partnerships, that we're proactive in how we monitor and mitigate risk in the supply chain, that we are looking and enhancing that transparency of where the product flow is, but that we also do that in a collaborative way with the host governments and other stakeholders that are investing in this area. So to dig down a little bit, I have to give a shout out to our maternal child health colleagues. They actually just funded an assessment through our PSM project in Zambia, I think recently in Mozambique, and I think even in Zambia they had maybe 49 wholesalers, in Mozambique maybe 100 plus, although only a handful of those are operational. So I think just, there's some interesting things going on there, but I think as we kind of look through these assessments, one of the things we're seeing also is the issue of the sub, the wholesaler to the subs to the subs to the subs, and I think that has an impact on price, obviously in price, to the consumer, but also then as you go further and further down, the issues with quality assurance. And so I think that's something that we have to pay attention to. There's, some, Prashant, I think you've written recently on this. There's some obvious consolidation that's happening. Maybe that's an okay thing, but actually that consolidation enables you to spread across some of those fixed costs needed. But at the same time, I think we want to make sure there's competitive markets. And so I think we need to be careful about too much, but I think a competitive market is really important as we start to engage the private sector and the public partnerships there. And then finally, I just would say in terms of some recent success, I would say the way we've approached the procurement and supply chain for the viral load testing in the PEPFAR space is one good example of where there's a strategic partnership happening there in the way contracting's done and moving more toward kind of a vendor-managed inventory approach, which really actually then uses the local distributors that are in country. And so I think if you look at that model, you can see how it's in the early days it was PEPFAR funding capital-intensive machines, right? The big cost up front to actually purchase the machine, and then to buy the reagents, to buy all the necessary components to run the test, and then to make sure that the machine was maintained and repaired. And so what we've tried to do with the PSM project and that approach is really to say we'd rather pay for the service. We'd like to pay for the test, we'll partner with your distributor in country. You make sure that the machine's running. You make sure that the reagents are there in the lab when they need to be there, and we'll pay a price per test. And so I think that's an example of, the interesting way of how to really build these private partnerships and bring in some of that work with distributors and wholesalers that may be in a country.
Excellent. So two things that I wanted to pose as minor follow-up questions before we move on. One is that you highlighted the example of the maternal and child health colleagues. And is it then the case that when we are not buying internationally, we have a stronger incentive to think about wholesalers, because then a large part of our commodity strategy depends on local wholesalers, versus if we are buying internationally, then in a way we don't have as much dependency. So something to reflect on as we discuss further in the panel. And then I think this is more general. As we talk about private wholesalers and distributors, we also ought to think about what do we mean? Do we necessarily mean private in the sense of private for-profit ownership? Because the colleagues who talked about China, we have Sinopharm, we have China Resources. These are state-owned enterprises. So if there are country governments who are willing to think about the equivalent of a Sinopharm or a China Resources and are willing to give the decision-making authority to the government agency and hive it off as a separate enterprise, we aren't necessarily saying that's a model we should discard. That's still a model worth thinking about. And then the last thing in this is there are also, for example, in Spain, the predominant form of ownership for 2 or 3 of the large wholesalers is a cooperative. So it's not a for-profit wholesaler, it's a cooperative. So I think we also have opportunities of state-owned enterprises, cooperatives, and for-profit wholesalers, which are all in the category of what we're calling as private. Just something to keep in mind as we are using the labels for us. Let me go to Lombe. Lombe, you have been instrumental in the design of this project in DRC. And one of the key concerns every time we've talked about allowing health facilities to purchase directly from local wholesalers is we don't know about the quality, we don't know about the price. You are allowing programming to walk into areas where there are risks on every step. Excuse me. So one, how have you managed this in the project in DRC? And also, what are opportunities to make the case for regulatory strengthening so that many of these problems that we keep seeing again and again can actually be addressed systematically?
Okay, great. Thank you, Prashant, and thank you so much, Clinton, for the presentation, and to all the panelists. So just to start with saying that I've been working in this field for about 15 years now, strengthening supply chains, and that's not a good thing when you're not making progress. And I also say that so that you don't ask me for ID when I get a drink at the cocktail. But so I think we've really reached an inflection point where we're finally looking at a more integrated model for delivering health services and pharmaceutical services. And this is something that my colleague Kara is here has been saying for a long time. We need to look at not just the public sector, but the public sector and the private sector, and really include all actors that are able to provide quality services. And then also just to say that we're working in contexts where funding is constrained. The predominant source of funding can, in some countries, be out-of-pocket expenditure. So whereas we're looking at strengthening our supply systems, and we've been focused very much on streamlined single-source quality assurance systems, we do need to work on a model that also assures that everybody else, not just the 40% of government and donor funding, but everybody else is receiving quality pharmaceutical services. So on the pharmaceutical services side, we're actually working with a colleague in the UK called David Todrup on, first of all, redefining what we mean by pharmaceutical services. So all the pieces, the pricing elements, which includes looking at markups from wholesalers. We're looking at supply chain, which now is including both the public and the private sector. We're looking at regulatory systems and how to strengthen regulatory systems, and I'll come back to that. And we're also looking at how to strengthen human resources. WHO is developing a capacity competency model rather for pharmacists, so that there is a clearer path towards different parts of the pharmaceutical supply chain. They can work in the private sector, they can work in the public sector, they can now work in industry. We're hearing that there's a huge gap within industry. So we're looking at human resources as well. But now coming back to the regulatory piece, it has been a recurrent theme that we need to focus on quality. We need to put the microscope back on strengthening regulatory systems. WHO likes to threaten us with statistics. So we know the one in 10 medicines in the countries that we work in is considered substandard. So I think our emphasis is to find the 9. If there's 1 in 10, we still have a lot of room to find the ones that are able to provide or to assure adequate quality. And that means really working with regulators. In the context such as DRC, where the population is almost 90 million, there are hundreds of wholesalers, hundreds of distributors. The manufacturing space is smaller, but it's still quite vast. So on the regulatory side, there are obviously a lot of constraints for the regulator to meet those 6 functions of a strong regulatory system. And it's interesting that you mentioned Tanzania. Clinton mentioned Tanzania as one of the countries where the regulatory space is still still needs a bit of effort. Whereas on the other hand, they have been considered by WHO as being one of the more reliant regulatory authorities in Africa. So we need to focus on the regulatory space, but the regulator cannot do this alone. So I think what comes into play now is really with the certification that Dr. Babo spoke about, how are we engaging industry both as donors and from the government side, how are we engaging industry to really help them self-regulate, so to become complementary to the formal regulatory processes that are being put in place or that are being strengthened. And self-regulation could be it could be formal, or it could be informal. It could be the setup of an industry body that professionally accredits or re-accredits suppliers that are able to perform on all the different aspects that were presented. And within this network, we can then rely on the self-regulating system to identify manufacturers that we as public entities can more closely work with. But this self-regulation can't happen organically as much as we would like to, although in Bangladesh it was sort of forced to happen because the speed at which the industry developed was much faster than the regulators' improvement. So for them to have access to the US markets and the European markets, the industry really had to come together and start a process of self-regulation. So I think in a context such as DRC, we do need to be more actively engaged and involved in helping on the one hand, helping the regulator in its formal regulatory strengthening processes, and we are moving towards getting the DRC to become one of WHO's more stringent, more reliant regulatory authorities. We are on good track for that. But then secondly, in parallel, working towards a self-regulation mechanism and supporting these wholesalers that are deemed to be able to provide good quality, supporting them to maintain those standards of quality, increase the standards of quality where that's deemed necessary, and support them in terms of providing incentives, in terms of laying out the market that's available. So in the case of the DRC project, there's an immediate market that has been presented to these private wholesalers. And if they maintain certain conditions, such as improving quality, their own internal quality systems, and so on, they do have immediate access to these markets. So I think the formal regulation and the more informal self-reliance mechanisms are things that we need to really focus on moving forward.
So thank you. And I think just one point of clarification, when you are referring to self-regulation, if my understanding from Dr. Babo's talk and our discussion earlier is correct, then it's not a, let's say, fair type of self-regulation. It is, if you want to sell to public facilities in the DRC, you have to be accredited. Otherwise, you cannot sell in this market. So in that sense, it's a self-regulation, but with a very strong market incentive tied to it. Which I think just adds some more gravitas to how self-regulation mechanisms operate in a more general sense. John, we've heard from Clinton and credit is a big problem. Wholesalers don't have fixed capital. Wholesalers' working capital, cash-to-cash cycles are very poor. So when we hear such problems, we come to John and say, what kind of financial instruments, innovation, what can we do? So do you have something?
Well, we do. First off, thank you, Prashant, for organizing this panel. I'm not so sure I'm thrilled to be cleanup on batting cleanup in such a august body. Thanks, Clinton, for and your team for a wonderful presentation. I'm eager to see the full report, but certainly the picture you described is one we're very familiar with. And we're in the business of trying to provide capital into this marketplace right now. And yes, it is absolutely a market that is facing very significant capital constraints. I mean, I think if you look at your typical distributor, you made the point about the high cost of capital. Many of these distributors have no access to capital at all, although they have maybe a little bit that they get by pledging personal guarantees, their homes, other property they have. But the assets, most of these hundreds of distributors in these fragmented markets are very thinly capitalized. They don't have a lot of assets. Their main asset are the invoices that they generate when they sell to customers on credit. And they often have to sell to customers on credit because so few of the underlying customers have cash to be able to buy the product to stock their shelves. A recent report that we looked at, a survey of several pharmacies in Kenya, noted that of the indicator medicines, the average percent that were actually available in the pharmacies was 43%. It was as low as 2%. At the high end, it was 73%, but never was it 100% among the survey sample they have. So the picture that you're seeing in many of these situations is a lack of product on the shelves and no capability without credit to get access to that product. The real sort of lever that we're looking at, and by the way, we got into this, Clinton in his presentation mentioned the medical credit fund, which is at this point probably the only facility that's focused on providing financing to the health SME sector in health. They're a long-term partner of us, and it was through them that we identified that there was a real challenge to lending to these institutions. The medical credit fund, by and large, lends through banks, and the banks need to see collateral. And they don't give any credit to the invoices as collateral. These are sort of pieces of paper. They can't go down and seize them at the court. They can't impound them. They can't put them in a truck and take them away. They don't really see them as something that adds real value. So the real lever that we're looking at trying to pull to create credit in this market is trying to take those invoices and turn those into a financeable asset. And there are two critical components to this. The first one, Clinton also mentioned in his report, data. That is, that piece of paper is meaningless if you don't understand what it represents in terms of the amount of cash that's likely to come back from owning that. A piece of paper to James might be 100% he's going to pay. Same piece of paper to Ann, maybe no, although Gates Foundation, they'll probably pay too. But that you have to have some data that tells you what's the likelihood that each of those pieces of paper are going to pay. The other thing you need to do is be able to do it on a portfolio basis. So there is a way, actually, for some distributors to get financing through the factoring systems that exist in many of these countries. And that's where they go down to a factoring company, usually a arm of one of the local financial institutions, one of the local banks, and they say, here's my invoices. Can you finance against them? And they'll say, who do we know here who we really know? And of this list of hundreds of thousands of invoices, we'll take 10 or 20 or 30, and we'll give you 50% or 30% for those. And the rest, we can't do anything. And what's happening to the distributor in that case is they're taking a huge discount on their best credits, and they're stuck with the least. What we want to do is create a situation where they can finance the whole portfolio based on the performance of that portfolio and the marginal cost of taking on somebody new, because that's really what we need to do. We need to extend the credit to new customers, because those are the ones who aren't getting credit at all, is relatively small. So the first, you start that process by getting the data from the books that these distributors have and taking a look at what that data looks like and seeing what the trading behavior of those various payers tells you about the likelihood to pay. And once you have that data, you can then create an advance rate that identifies that if we advance 50%, there's almost a guarantee that we'll at least collect that much, so we can finance that. If we advance 60%, still very high. 70%, maybe it gets a little sketchier. And you want to set that advance rate at a level that's consistent with the risk that your investors are willing to take. The other important point about collecting all that information into a sort of a data engine is that you can see what the problems are and how you fix that problem. So one problem you see consistently is a plethora of credit notes. Credit notes occur when you generate an invoice, but when it comes time to collect, the customer says, I didn't buy that. And then you have to say, oh, sorry, my mistake, here's something else. Well, if you have all those credit notes, it really creates a grossly inefficient supply chain between the customer and the distributor. And you have a product that goes there, comes back. You have a very tough time of knowing if that customer will pay because they might dispute the invoice. And one thing that dramatically improves the likelihood of payment is that you get the customer to confirm that they actually received the product in question or ordered the product in question before you issue the invoice. And then those invoices become much more there's a much higher likelihood of payment. And there are all other sort of issues you can identify once you have the data that's on hand. So part of what we've seen, and we've been working with distributors who are already on the platform, and their performance is already improving, is that just having the data is a big step forward in terms of creating a better, more functional system. But then once you finance, that then means that for the distributor, that extending credit to the marginal customer is much less costly because the whole portfolio is the credit, and that extra customer is not going to change that advance rate that much. And if the extra customer turns out to be a great payer, the advance rate's going to go up. Not so much, then you work with that customer to either improve their payment behavior, or eventually you'll have to suggest that they pay more in cash or find a new customer. But the point is, you create incentives to improve the payment behavior of your customer. That improves your advance rate. That gives you more cash in at the outset that allows you to buy more product and extend more credit to even more folks and create a virtuous cycle that ultimately allows there to be much more product on the shelves and more sustainable financing for the institution. And last point I'd make, and then allows them to use the assets that aren't their invoices to finance the long-term fixed assets that Ann was talking about, instead of using whatever collateral they have to support their working capital.
Excellent. So Clinton and Ann presented, in your report, you presented wholesalers, which are almost at the high level, quite a few of them. You also surveyed them about capital constraints. So if you have the ones which have capital constraints and are at high level, and you have some kind of an invoice financing vehicle, we have found a solution at this panel. And then all we have got to do is go to the development finance institutions and present this as a case where we can do this more systematically once your early results come out.
Absolutely. So we're financing it. You know, we're working with a small group to initiate the initial financing. We are talking to the DFIs about providing some sort of guarantees as we take this to capital markets, but ultimately, we want the main source of financing to be local investors, local financial institutions, local pension funds, banks, so that we take the currency risk out of the equation. So it is important to say that one real benefit of doing this model is that the currency risk today sits often with the distributor. They pay for their commodities in dollars. If they give credit terms to their customer, those are in local currency, and they bear the risk until their customer pays. This takes a big part of that risk off the table for them.
Thank you. I know you have questions, comments, remarks, so, and also the ones who are watching us on webcast, please use Twitter or other means. So the way we're going to do this is we'll take questions in rounds of 3. Questions can be for the panelists or for Clinton or Dr. Babo. If you have a question addressed to anyone in specific, please say so. Introduce yourself, keep your question short. And if it's a question for Dr. Babo, we will make sure that we have we get that translated, both the question and the response. So with that, questions, comments? Yes.
Hi, good afternoon. My name is Emily Kobayashi. I'm with the Clinton Health Access Initiative. I have a sort of existential question about is what we're talking about the right thing to be doing? And are there instances where focusing on private sector entities could be to the detriment of strengthening public sector entities. What really struck me about Clinton's presentation is that a lot of the challenges that the private sector wholesalers highlighted are also challenges faced by public sector or semi-public sector entities that are trying to deliver sustainably. And then you also have the profit motive and some of the other challenges that come into play with the private distributors. So I guess, want to ask, as we see opportunity on the private sector, are we turning our backs on strong public sector supply chains where those could exist?
Good. Thanks, Emily. Other questions? Yes, Silas.
Hi, Prashant. How are you? This question is for you, actually. So I think, and you maybe be able to guess what I'm going to ask about, but I think the classic example of an initiative that harnesses the power of the private sector, of the distributors, is the Affordable Medicines Facility for Malaria. And I just wonder, now maybe 8 years later, folks might not be familiar with it. And I was wondering if you could, talk through some of the high-level findings from that, and then what are the, as you see it, lessons that we can learn from that in terms of using private distributors to meaningfully impact access.
Excellent. Thank you, Silas. Yes. Simon.
Hi, I'm Simon Conesa, formerly with the Norwegian Refugee Council. So my question is for the panel. It has a couple of areas. So we are talking about first lack of data and wanting to have end-to-end visibility on where the products go. And the other one is the lack of finance and how we can improve the access to finance and perhaps take part of the risk of the exchange rate. So I'm wondering if anyone here in the room or in the panel is considering using blockchain technologies to one of these two problems, because there is a lot of excitement and it's a little bit now, there is a little bit of exhaustion of hearing about that, but we don't see that many examples of applying it. So I'm curious.
Thank you, Simon. So we'll start with those three, and then in the meanwhile, I encourage you to think about questions, things you want to comment on. So let's start with Emily's question. Why don't we ask Lombe to start? Why this focus on private sector? Clinton says the private sector wholesalers aren't necessarily very far apart in the quality performance. So why are we even doing it?
Good, great. No, that's a really good question. So I think what we're trying to say, or at least what we're trying to say from the bank's perspective, is not necessarily to focus specifically on the private sector, but to focus on entities that are able to perform and deliver pharmaceutical services. So for a long time, we've been working solely on strengthening the public sector because we've had concerns about quality, we've had concerns about pricing, we've had concerns, several different concerns have brought us to work with public entities. Now there's a diminishing, those aspects are diminishing, so we need to focus more on efficiency and performance. And that means opening up to several different entities. And the private sector so far is essentially showing results. So we're going to encourage those entities that are able to be certified, that are able to provide these services to participate. And as we said, there's financing available, and we're working towards building a system of providing structured support towards these entities. But if the public sector can keep up, and I challenge them to do so, where we're not restricting to any particular segment of the health sector.
So one thing I would add to that response, Emily, is that if the public sector agencies which are managing procurement and distribution are able to demonstrate the kinds of performance and efficiency targets that we are setting, which will require governments to give the executive management of those public agencies many more degrees of freedom, much more direct authority, including some fiduciary responsibility and management of that, some ability to take risks, which have become very hard and challenging things to do in public sector agency reform. And wherever there is enough state capacity and we see that governments can do that, I think that should be the right model. But where we don't see state capacity getting us there, that's where perhaps we are to look at private sector.
Sorry,
Mark,
just incidentally, also just to mention two things quickly. In the DRC, the idea was also to turn these public entities more into private entities by calling them they were sort of registered as independent NGOs providing services to the government, and that was in theory supposed to give them the freedom to do what Prashant is talking about, but still that didn't quite work. So with the certification, the public entities are also invited to participate, and incidentally, we haven't found a lot of them qualifying to the standards that have been set by the regulator. So the public entities haven't quite entirely qualified. It's varied, but they haven't quite met the mark.
So the idea should be sector agnostic performance contracting, where you say this is the performance we are seeking, sector agnostic. If a public entity or public agency can deliver that, that's great. If not, private should be eligible too. That's sort of the direction we're heading. Mark, do you want to make any short comment on why are we focusing on private wholesalers and distributors?
I think my short comment, Prashant, would be that entities do core competencies best. Governments are very good at regulating. Industry is good at operating within those regulations in as efficient manner as possible. And I think what you've seen in a lot of the most developed countries and healthcare systems are companies that have become very efficient and perform at the levels that are required in order to make sure the quality and efficacy of the drugs are in medical devices are high, and that the availability levels are high, but they are also intensely regulated. So I think that is a good formula, notwithstanding the fact that the Chinese have taken that and turned it a little bit with the state-owned enterprises. Even in that environment, the state-owned enterprises are operating as a private enterprise, and certainly regulation is enforced in some ways through ownership. But in terms of what we've seen across the globe and across the various markets, that seems to be the best combination, a strong regulatory environment over a strong industry.
Thanks, Mark. So Silas's question, I'll be very quick. This can be, we can have a much longer discussion just on what we learned through the Affordable Medicines Project. But I think, like you said, 8 years later, I think we are at a unique point where things that we found to be challenging in the past have changed because the landscape has changed. The first is the key that quality of care doesn't necessarily improve even though availability improves, and quality of care being diagnosis, other things. I'm not saying that public sector is necessarily doing better, but I think we didn't have enough answers to whether quality of care improves, including diagnosis, when we use the private channel for antimalarials. And I think that's where things are progressing, not probably at a point. The second is our ability to collect data has become much better. That's where we've progressed in almost a transformative way, where now we can think about the price, what is selling, in ways that we didn't know before. And I think we learned from the AMFM that if the objective is to improve availability, that's an easy target. That we can do very quickly through a private sector subsidy, a private sector incentive program, et cetera. What is tricky is availability combined with quality of care in a broader sense and managing channel markups. And I think it is probably opportune time to say, where are we 8-10 years from the early AMFM pilot to think about where technology, market structure has brought us today. So yeah, very interesting conversation. Stay tuned. We may come back with ideas to you. The last question was about blockchain. So any of the panelists working on blockchain? Simon's question was, you talked about data, you talked about finance. It seems like the convergence of that should be right for blockchain. So,
so we work with a technology partner, a financial technology company called Capital Tool Company, and they are in essence manage the data engine, and so blockchain for them is just one other tool that they could use, and obviously the conditions have to be suitable on the ground. You have to deal with some of the data ownership issues. Right now, that data is owned by the distributors, and the question is, would you move to a model where that data would be owned by someone other than that so that it could be on a distributed ledger. I think the way to look at blockchain is sort of the same way to look at public versus private. It is one other tool that can be used if it's more efficient, if it makes things clearer. But it's not an ideological issue. It can be a tool that's useful or a tool that's not.
Okay, one additional round of questions. We have time for one round of questions. So I'll start with Maureen here, and then yes.
Maureen Lewis, Atesto Global. Thank you. This is a great panel. There are a couple of things I wanted to ask. One is, we talk about regulation, and there's very little of it, actually, in much of the developing world, especially in Africa. And the question, is there a path to regulation? We're working in Angola, and again, it's sort of lots of distributors, nobody knows what's going on, and there are no drugs anywhere. Outside of the pharmacies. So it's probably very similar to the kinds of things that you found, and I'm hoping we can draw on that. But I'm wondering if there is anything that sort of takes you on a path, because we have what we do in the developed world, which is very sophisticated. What is the path of how you get there, what you do? So that's one question. The second question I wanted to ask Dr. Babo in the DRC about accrediting the number of distributors that they had, what it cost, how that made a difference in terms of being able to control and regulate, or is it too early to tell? But we'd like to very much learn from what you've done. So thank you.
Okay, yes.
I had a question. It's sort of like this old saying, the red herring. Sort of like the old saying, the red herring. In the Chinese mixed economy, they have state banks. We used to have them in the U.S., and California's starting up one. If you're a private drug distributor and you take loans from the Chinese bank, the state bank, the Chinese government has a remarkable way of dealing with things. Unlike a U.S. distributor who would face bankruptcy, the Chinese board on that bank could decide, you know what, cost-benefit-wise, let's not let this place go down. We'll pump money into them to keep the people employed. Mm-hmm. So I don't know how you can come up with a kind of categories, because somehow you get into this gray zone. I'm kind of confused. Thank you.
Julia, you have a question, I guess, from an online participant.
Yes, we have a question on Twitter from Population Council. Can you comment on how to help wholesalers and distributors surmount the barrier of generating demand, especially for new products?
So here's what we'll do. We'll start with these three, and then we might take one more round of questions after this if you all are willing to stay for a few extra minutes. Let's start with pathway to regulation. Maureen's question on, do we have a pathway? Any of you want to comment on that?
Well, I'll try a little bit. And I think this is what we were hoping our distribution association that we're working with in Africa will begin to be a genesis for, because we hope this organization will work with the governments in the territories in which they're operating to try to help to increase the amount of regulation and bring in the right kinds of regulation. A lot of complex issues there. There has to be a commitment on the part of the government. There have to be the funds to do it. There has to be the expertise to do it. How you get that part of it, I don't know. But I think industry has to extend the hand to the governments to start to get a process started. And then how it's received and how fast it happens depends on the local conditions. But in all cases, what we've experienced, healthcare is a local phenomenon. As much as there are global issues, ultimately it's a local phenomenon. It requires the local regulatory agencies to work well, requires the industry to work well, and it's best when they work together.
So Maureen, the short answer is it requires a panel in itself, which would be yes, pathway to regulation. Your second question was to Dr. Babo, so would you like to reply and then we'll translate?
Oui, merci pour la question. Je voudrais dire qu'il y a, par rapport au coût, je ne saurais pas donner la réponse par rapport à ça, mais
Thank you for the question, and I will do my best to give you an answer.
Mais par rapport à la question de l'accréditation et la réglementation.
Going back to accreditation and regulation.
Il faut dire que pour nous, l'accréditation, c'est un dispositif supplémentaire pour renforcer la réglementation.
For us, accreditation is an additional mechanism that allows us to strengthen and enforce regulation.
En fait, la question qu'on pouvait aussi se poser, c'est si on pouvait dire, si les fournisseurs sont là, on suppose qu'ils ont eu les autorisations pour être là.
Another question you might ask is, well, if the wholesalers are there, then they must have gotten the right licensing or authorization to be there.
Oui, malheureusement, comme on a dit, nous sommes dans un contexte où la régulation est faible.
But unfortunately, as I said, we're working in a context where regulation is very weak.
C'est ce qui fait que l'accréditation est un dispositif en plus pour renforcer cette réglementation.
So again, we're using accreditation as an extra mechanism to strengthen our regulations.
Thank you. Question about how can wholesaler distributors create demand? How can we enable them for demand generation? And this could be not just for pharmaceuticals, but also medical devices. Any comments from the panel? Clinton?
In our experience working with the distributors, demand has not been their problem. I think getting the licenses for the product is a problem. And as Clinton pointed out, many of them have exclusive licenses. So, the one distributor will have the one license. But if they have the product, the demand for healthcare in Africa is growing at an incredibly high rate. And we don't see too many distributors whose issue is, I need to find more customers. Their issue is I need to be able to sell to more customers who don't have the financing to pay for our product.
I guess let me rephrase the question. I'm making a presumption here based on what I think the Population Council colleagues are asking. So if you have a new health technology or a new health product for which the market is not as visible and clear to the wholesalers, how do we incentivize them and enable them to generate demand? That's, I guess, more along the lines of what they might be asking us. Clinton.
So two thoughts on that. The first is I agree with you, Simon. One of the comments we asked was,
do you seek manufacturers or do manufacturers seek you? And they were like, well, it's about 50-50. We get seeked out as often as we seek new distributor relationships. So there's definitely a robust relationship between manufacturers and distributors. But when I was at Imperial, this issue came up around demand generation. And there are a number of wholesalers that have got some really interesting models around demand generation. So you've got wholesalers that have got this, what you would call sales, like a sales force that go out to pharmacies and clinics and hospitals and go and create demand. And we see this in things like oncology products that are very specific. So I think with the right partner, depending on the markets, obviously this would be more mature these would be more mature markets that have got more resources as wholesalers. But if you're seeking to try and launch a new product in a market, I think you could find in some of the more developed African markets that we visited, you would find partners that could go and do that on your behalf.
Okay, thank you. I think we're going to take one or two questions from this side, given that there were people on this side who wanted to ask, and I'm just going from the left to right.
Do you want to answer that question, the middle question about sort of a Chinese model?
Do you want to answer, Mark, or?
I'll try to give you a quick answer. I can't explain the Chinese financial system, so I'll leave that part alone. But I will say that the state-owned enterprises is not the exclusive model in China. There are pure private operators as well. The top two companies happen to be state-owned, and from there, it varies the level of state ownership, but there are a number of companies that are purely private that are not state-owned.
Thank you. Thanks, Mark. Maeve, and then we have someone at the back. So last two questions, and then we wrap up after that.
Excellent panel, and thanks for organizing it. So for me, I think the manufacturers play a key role in all of this, and we haven't talked very much about it. So I think it's interesting to maybe think about it in terms of how can we leverage the manufacturers to actually help strengthen a lot of these channels, because that's what they're going to use. But I also think it's interesting to think about how to leverage them for servicing the public health, like they're doing in DRC as well. So one of the things myself and Prashant always talk about is if we could change the Ecoterms, so that the Ecoterms, then what impact would that have? But also, John, I think in terms of the work that you're doing, which is also, I think, really good, how can we get the manufacturers also to get involved in underwriting some of this credit as well? Thank you.
Excellent. Thank you, Maeve.
John Hedderly from McFadden PAE. Good afternoon, everybody. Great presentation today. Quick question for anyone on the panel. Clinton did a great analysis of the wholesalers and distributors in that 9-month study that he alluded to, but it's a very small sample size. How would one on the private sector side go about identifying the universe of capable partners in some of these countries that we've been talking about today?
Okay, so my suggestion is, Clinton, do you want to answer the sampling framework so that it's not just 47, there were more? Yeah. And then in the meanwhile, the panelists will give some thought to Maeve's question of changing Incoterms and manufacturer role in also the credit provision. I guess one of them is directly to you, John, and others about manufacturers. So, Clinton.
So, we catalogued hundreds of wholesalers in each of these markets, and we've created registries for each of these countries. And there's some issues we've been debating with the foundation, because some of this information is sort of proprietary information, like their revenue and how big they are, how many people they employ, versus just there's a long list of names of people with phone numbers and website addresses. So that's just a small thing we need to nail down on, because we bought that data from various sources, and so those people who we bought the data from obviously don't want us to publish it. It's their data, so there's some issues there. But there is a registry with a whole list of all of these that will be made available. To what extent we're able to share detail within those registries is something we'll iron out in the next couple of weeks.
Thank you. John, do you want to start with?
I mean, so manufacturers are a source of credit for many distributors now. They do provide terms. The challenge is, if you're talking about the hundreds of distributors that Clinton's talking about, the manufacturers are only going to provide terms to the ones they know and they trust, and that's a small segment of that group. And then again, they only provide them for a small fraction of the cash cycle. So it's to push. Well, I mean, I think one answer, of course, is the better data they have on the underlying customers, the more likely they'll be able to provide credit terms, and the longer they'll be able to provide credit terms. Of course, they'll only do that if they believe the underlying customers will also are folks that they can have some confidence in. Consolidation obviously would help to some extent, but I don't know if we want to sort of put our finger on the scale one way or another on that, for the reason that James was talking about the issue of maybe creating too little competition. So I do think you can encourage I think if you better data, stronger balance sheets, more established distributors can lead to more extensive credit terms, but that will always only be part of the solution, not the whole solution.
James, so I'm just posing that question more directly in the interest of time.
Yeah.
Contracting manufacturers to do decentralized delivery versus receiving deliveries from them at an international or at the port of entry level.
Yeah.
That will change the way the distributor market operates.
Yeah, I think that's certainly an option. I think and again, it's if you take a look at what's been done under how we've managed the viral load procurement, it's to do a similar type of deal. So I think there are other spaces you could do that. Other manufacturers where you could get more of those incentives aligned, where then there is an interest for them to be investing further down into the supply chain to ensure availability at whatever that Incoterm would dictate, whether that was at a central level, a regional level, down to where the service delivery happens. So I think, yes, that's certainly one option, is to use your Incoterms as you do that. But I think, again, it's right. It's where are you putting the incentives, and acknowledging how that's happened in the past and where you might have opportunities to change that going forward. And then how is risk either distributed or shared among those actors. And your example, if you're buying straight from a manufacturer in India, then you hold all that risk from that point on. So I think looking at those kind of options where it's a alignment of incentive and a sharing of risk is quite key.
Okay, with that, let's thank our panel. Thank you. And thank you to all of you. There is a reception waiting outside, so please stay if you can, and there'll be more opportunities to discuss with the participants and the panelists. Thank you again.